January 20, 2026. The pandemic sirens have been silent for years, but the virus hasn't left. It's simply moved in. We are now living in the endemic era of COVID-19, a phase defined not by lockdowns, but by a new set of biological and societal realities. A mutated XFG variant is dominant. Over 57,000 new cases were reported globally in late 2025, and millions continue to grapple with the ghost of the virus, long COVID. But this new phase raises profound questions. What does the virus look like now? How has it changed us permanently at a cellular level? And what is the true long-term cost of living with the virus? Welcome to Health Inside, Anatomy and Science. Today, we're conducting a 2026 status report on SARS-CoV-2. We will map the evolutionary path to the XFG variant, dissect the persistent biological mystery of long COVID, and examine the emerging data on the virus's lasting imprint on our collective health. This isn't about fear, it's about foresight. Part 1. The Virus in 2026, Evolution of a Persistent Pathogen. The virus of 2026 is not the virus of 2020. Through relentless mutation and natural selection, it has optimized itself for one goal: persistent circulation. The dominant strain, XFG, and its sublineages like XFG.14.1 represents the culmination of years of Omicron-era evolution. Its key adaptations: enhanced immune evasion. XFG's spike protein carries a complex array of mutations that allow it to partially escape antibodies generated by prior infection or vaccination. This doesn't make vaccines useless, it makes them essential for updating. Upper respiratory tropism. Like its Omicron ancestors, XFG prefers to replicate in the nasal passages and bronchi rather than deep in the lungs. This makes it more transmissible. You cough and sneeze it out more easily, and often leads to less severe initial pneumonia, though severe outcomes are still possible for the vulnerable. Stealthier spread. The continued reduction in severe acute illness means more people are transmitting the virus while experiencing mild, cold-like symptoms or even no symptoms at all, making containment through symptoms alone impossible. The 2026 strategy is not eradication, but mitigation through updated immunity. The seasonal booster campaigns, like the one in UK with a January 31st, 2026 deadline, are our new annual defense, akin to the flu shot. Part 2. Long COVID, the defining medical mystery of the post-pandemic era. For an estimated 6% of infected individuals, tens of millions globally, the acute infection ends, but a chronic, multi-system illness begins. Long COVID is not one condition, but a constellation of syndromes with likely multiple overlapping causes. The leading pathophysiological hypotheses for long COVID include viral persistence and immune dysregulation. Fragments of viral RNA or protein, the viral ghost, may linger in immune-privileged sites like the gut, nervous tissue, or vascular endothelium. This creates a state of chronic, low-grade immune activation and inflammation. Autoimmunity. The infection may trigger the production of autoantibodies, immune cells that mistakenly attack the body's own tissues. These have been found targeting G-protein-coupled receptors that regulate autonomic functions, explaining conditions like POTS, postural orthostatic tachycardia syndrome. Microvascular clotting and endothelial damage. Researchers are identifying amyloid fibrin microclots in the blood of long COVID patients. These are not normal clots. They are resistant to the body's natural clot-busting processes. They clog microcapillaries, creating microscopic ischemia, oxygen deprivation, in muscles, nerves, and the brain, directly explaining post-exertional malaise, or PEM, and brain fog. Mitochondrial and metabolic dysfunction. The virus may damage or reprogram mitochondria, the power plants of our cells. This leads to a cellular energy crisis where even basic activities demand a physiological cost the body cannot pay. Neurological invasion and neuroinflammation. Evidence suggests the virus can trigger, in some cases, persistent neuroinflammation and may even directly infect astrocytes, the support cells of the brain, disrupting neural networks. Long COVID represents a massive, unfolding chronic disease burden that healthcare systems worldwide are only beginning to quantify and treat. Part 3. The Systemic Legacy: How COVID-19 Alters Long-Term Health. Beyond long COVID, large-scale epidemiological studies are revealing that even recovered individuals face elevated long-term risks. SARS-CoV-2 infection is not just a lung event, it's a systemic vascular and inflammatory event with lasting repercussions. Cardiovascular system. Studies in Nature Medicine and elsewhere show that in the year following infection, individuals have a significantly increased risk of heart failure, stroke, myocarditis, and arrhythmias, regardless of the initial infection severity. The inflammatory insult can destabilize atherosclerotic plaques and damage heart tissue. Metabolic system. New-onset diabetes risk is elevated post-COVID, likely due to pancreatic damage and increased insulin resistance from inflammation. Neurological system. Increased incidence of anxiety, depression, cognitive decline, and disorders like Guillain-Barré syndrome have been documented. The virus's effect on the brain is both direct, via neuroinflammation, and indirect, via systemic illness. Some research points to a depletion or exhaustion of certain immune cells, like T cells, potentially creating a window of vulnerability to other infections. This data suggests that the total mortality and morbidity of the pandemic will be tallied not just in acute deaths from 2020 to 2023, but in excess cardiovascular, metabolic, and neurological disease for decades to come. Part 4. The 2026 Toolbox: Prevention, Testing, and Treatment. Our approach in 2026 is more nuanced, targeted, and integrated into routine care. Prevention: the layered defense. Updated vaccination: the cornerstone. 2025 to 2026 monovalent boosters target XBB.1.5 or later strains, providing the best available protection against severe disease from current variants. Strategic masking. High-quality masks, N95 or KF94, remain a powerful personal tool in high-risk settings, when crowded indoor travel or during local surges. Air filtration and ventilation. Recognition of airborne transmission has permanently changed building standards. HEPA filters and improved ventilation are now recognized public health tools. Testing and diagnosis. Rapid antigen tests are ubiquitous for symptomatic testing. PCR testing remains crucial for diagnosis in clinical settings and for sequencing to track variants. The key shift is integrating COVID-19 into the differential diagnosis for any respiratory or unexplained chronic illness. Treatment: the antiviral window. Paxlovid, normotrelvir, ritonavir, and other antivirals are standard of care for high-risk individuals within 5 days of symptom onset. The challenge in 2026 is ensuring access and uptake, as many treat COVID as just a cold and miss the critical treatment window. Part 5. The Social and Legal Aftermath: Trust, Fraud, and Mandates. The pandemic's legacy is not just biological. The report of an $824,000 COVID-era fraud in early 2026 is a footnote in a vast landscape of exploitation and misinformation that eroded public trust. Simultaneously, rulings like the January 2026 Canadian court decision upholding employer vaccine mandates, even if later proven based on imperfect science, highlight the complex interplay between rapidly evolving science, public policy, and individual rights. These legal precedents will shape responses to future health crises. The endemic era demands a new social contract, one built on scientific literacy, clear public communication, and shared responsibility, moving beyond the polarization of the pandemic's peak. COVID-19 in 2026 is a transformed threat. It is a quieter, more insidious presence, a virus that has traded some virulence for transmissibility, leaving in its wake a chronic disease crisis and an altered risk profile for millions. Understanding this new phase is critical. It means getting your updated vaccine not out of panic, but as routine maintenance. It means recognizing long COVID as a legitimate physiological injury. It means viewing a COVID infection not as a binary recover or die event, but as a systemic stressor with